morning, everyone, and welcome to the Geriatric Psychiatry Web Education Series. I believe this is session 2 right now. We have Dr. Amy Gough presenting for us today, one of our own, a geriatric psychiatrist. Just a couple little reminders before we get started. If everyone can keep themselves muted throughout, that would be great. We are being recorded for this session, so just a reminder that that is happening. If you have questions, put them in the chat. We will get to them at the end of today's session. And just as well, our Secretary Elle will put a link in the chat for those of you that require credit or fill the form for attendance. So with that, I will hand it over to you, Dr. Gough, and
Thanks.
you can go ahead and get started. Yeah.
Thanks, Caitlin. Can you hear me okay? Is the volume all right? Okay.
Yeah.
So thank you for the introduction. My name is Amy Gough, like Caitlin said, and I'm a geriatric psychiatrist practicing out of Dartmouth here in Nova Scotia. And so today the topic that we'll be looking at is psychotherapy. But because psychotherapy is such a broad topic, I'll focus mostly on one of the most evidence-based therapies that is cognitive behavioral therapy, or CBT. And so we'll go through kind of what that is, but also talk about some strategies that can be used practically in settings where you don't have access to a psychotherapist or you don't have formal psychotherapy training. So hopefully it'll be a bit of an overview, but also with some useful tips. So for the session, I'll start off by giving a brief overview of common psychotherapies that are available to older adults. So what's accessible, what tends to be effective, and then how to kind of choose between them in real life, in real clinical settings. From there, we'll move into some of the core principles of CBT and really just get into kind of the foundations, what a typical session of CBT looks like. And then we'll also review some of the common clinical indications. So when you would think about using psychotherapy in late life. And then, as I briefly mentioned, a key objective is to highlight some practical CBT informed strategies that aren't necessarily a formal course of psychotherapy that you can use in the context of care, regardless of what your specialty area is. So whether you're in nursing or working with clients, even in OT, there's lots of different ways that these tools can be implemented kind of independent of your specialty necessarily. So I'll be curious to see if there's any questions about that after we go through that part about kind of the more practical aspects of CBT. And then if we have time, I will do a brief overview of a randomized control trial that is currently underway here at Dalhousie and running out of the geriatric psychiatry clinic in Dartmouth and Halifax. That's looking at evaluating a group CBT program that has been adapted for use with older adults and kind of comparing that to usual treatment. So we've got a few things to cover, but hopefully I'll keep you entertained. So I have, for conflicts of interest, I just put here that I am the treasurer of the Fountain of Health Nonprofit Association, which is something we'll talk about later in this talk. And I'm also a co-investigator on that randomized control trial that I mentioned. The principal investigator is Dr. Cassidy, who's one of our geriatric psychiatrists here as well, but I don't have any financial relationships with either of these affiliations. So to start off, doing an overview here of kind of the main psychotherapies that are commonly used in older adults. So today we'll be focusing on CBT, but I think it's important to kind of understand the broader landscape and what other therapies could be considered for older folks. So CBT has a lot of evidence for a variety of conditions. So it's used in depression, anxiety, insomnia, chronic pain, and it's a very structured, skills-based program that can be adapted to a variety of levels of cognitive and functional abilities. So we'll break down the core components of that a little later. Behavioral activation is especially relevant in late life. It's actually a part of CBT. It's a component of CBT, but it also has evidence as a standalone treatment. And it really focuses on re-engaging people in meaningful, rewarding, or structured activities to counteract kind of the withdrawal and inactivity that often comes up and maintains depression. So it's really about helping people set behavior change goals, essentially. And in practice, this is a really practical tool. This is part of what we'll talk about you can use in your own practice, because even really brief interventions where you're helping people get back on track with their kind of positive health behaviors can have big impacts on cognition, mood, and overall function. Interpersonal therapy, or IPT, is particularly useful for older folks because it has four kind of core focus areas, and those include grief and role transition, which are really commonly experienced in older folks. So whether that's retirement, changes with independence, kind of grief, the loss of a partner, etc. So that's another kind of here and now therapy that focuses on one of those kind of main areas. So this is one of those treatments that you would need to have kind of access to a therapist to do a course of IPT. Reminiscence and life review therapies kind of leverage older adults' experiences, and it's an approach that helps integrate a person's identity, and it can be really helpful for individuals dealing with adjustment as they get older, or even early dementia. And again, this is one where you're really focusing on reviewing the past and kind of incorporating a lot of their past experiences and doing some emotional processing around that. Then there's supportive psychotherapy, which is a really common type of therapy because it is less intensive, I would say, than some of the other options, in that it focuses on coping, resilience in difficult situations, and it can be used when there is more cognitive impairment, limiting more of a structured intervention. So this might be an example of one you would use, for example, in somebody who has like a mild dementia and is not able to do a structured therapy week to week, but is still really struggling with the diagnosis and could benefit from some support and counseling. So problem-solving therapy, the next one. This one is also kind of a practical treatment that helps older adults facing specific challenges and trying to come up with solutions for it, essentially. So exactly as the name sounds. So this can be really useful for people with depression, but also with functional limitations or disabilities. And the last one we'll talk about today, noting that, again, this is not a comprehensive list, but these are some of the common ones that you will hear about, is mindfulness-based interventions. And lots of you are probably familiar with this just from kind of popular media and popular culture. There's a lot of information out there about mindfulness. And essentially, the crux of mindfulness is promoting awareness of the present moment in a non-judgmental way to reduce stress and improve emotional regulation. So this is one that can be really adaptable and delivered in a number of kind of high intensity or low intensity formats, just using mindfulness-based skills. And it's a technique that's often incorporated into the other therapies, including CBT. So when we talk about these intensive interventions, we're really referring to the structured formal psychotherapy delivered by clinicians with specialized training. So that would be things like a full course of CBT, IPT, or perhaps like a trauma-focused therapy, depending on the client's needs. And these approaches are highly effective. And for many older people, they can be really life-changing. but they're also pretty resource intensive. So they require time commitment, consistency, often meaning weekly or biweekly sessions with a therapist who has the training to deliver those skills. And as many of you know, in Canada, but particularly in Nova Scotia, much of this work would happen at a tertiary center or through private practice. So people would have to be seeking out a private therapist, and that may raise financial barriers if someone doesn't have, for example, coverage on their insurance plan for a course of psychotherapy. So while intensive psychotherapy is an excellent option when it's available, we also need more practical approaches that clinicians can use every day, and that's kind of why we'll talk about the CBT and the techniques from that you can use without access necessarily to these interventions. And just a word on some of the specifics to therapy for older people. And so older adults bring unique experiences and also challenges to therapy. So many have had high rates of loss, big role transitions, changes to their independence, perhaps. And these are some of the central themes that really influence how the therapeutic approach could be most useful. So, like I said before, someone with prominent grief might benefit more from something like the interpersonal psychotherapy. So, really focusing on that grief, and working through that. Someone who has depression and more difficulties with motivation and social isolation perhaps could benefit from more of a behavioral activation or CBT based approach where you're really helping them get back into routine in their day-to-day life. And comorbid medical and functional limitations are also more common in this population. And as we know, anxiety and depression often intersect with chronic illnesses like heart disease, chronic pain, or cognitive impairment. So the therapy really needs to account for these layers. There can also be greater stigma around mental health treatment with older cohorts. So this could influence a person's willingness to engage. And so, as clinicians, it's important to normalize the idea of therapy, and sometimes involving caregivers in this discussion can be helpful to increase someone's motivation to participate. And on the cognitive side, as part of normal aging, there can be slower processing speed, reduced working memory, and these don't preclude somebody from doing psychotherapy, so even the formal psychotherapy sessions, but they do shape how we would pace the sessions and present the material. So sensory limitations like hearing or vision loss could affect their communication in session, for example. And so this is going to have to be considered when looking at the structure of session, the types of materials that are being used, and even environmental considerations like what's the lighting, what's the noise level while you're doing therapy. And we'll talk a bit more about these adaptations with respect to CBT specifically when we get a little further along. So we'll move now into more specific components of CBT to give you a sense of, in more detail, what this actually looks like as a treatment. So for a really simple overview of what CBT actually is, it was developed, it's a therapy that was developed in the 1960s, 1970s by a now famous, now deceased psychiatrist, Aaron Beck, who observed that patients' emotional difficulties were often linked to patterns of distorted thinking or unhelpful thinking patterns. And so his work laid the foundation for this structured approach on identifying and modifying unhelpful thoughts and behaviors. So CBT is structured. You'll hear me say that over and over again because it really is like a manualized structured treatment, and it's time limited. So unlike open-ended talk therapy, it follows a really clear roadmap with specific goals, specific skills that we work on session to session. And the central idea of CBT is that our thoughts, emotions, and behaviors all influence each other. So when one part of that system gets stuck, like unhelpful thoughts, or maybe it's avoidance behaviors, we start to see the emotional distress. And CBT helps people to interrupt those patterns when they get stuck. So it's very action oriented. We're focusing on building skills that people can use right away in their daily lives. And the emphasis is on present focus change rather than exploring their past history in depth. And importantly, CBT has a very strong evidence base. It's been researched extensively. And it does tend to show for depression, for example, lower relapse rates in some of the longer studies compared to things like medications alone, which makes sense when you think these are skills that a person can continue to use in their everyday thinking and behavior to prevent relapse. So this slide this was borrowed from Dr. Cassidy. And this slide shows the link between thoughts and emotion and behaviors, just with a simple example. So for example, if somebody was having thoughts like, I don't have time for my self-care or exercise, which could be associated with emotions of sadness, for example, that could also contribute to sedentary behavior because that thought is kind of on repeat. With behavior activation, a part of CBT, you would perhaps set a goal to do something like get out for more regular walks, even if the motivation's not there, about scheduling in this behavior that something you want to do and that will likely be beneficial to you. And over time, as you do that behavior, the thoughts start to change. So I must care about myself and my health. I can do this. So more positive reinforcement about achieving the goal that was set. And then that's what contributes to improved mood. Perhaps it's lower anxiety. And so you could get into this in a lot more detail, but that's just a really simple example to show you how these areas are all related. And so CBT, the core principles, so what are actually the strategies that we use? I'll just highlight that really the principles of treatment are the same, whether you're doing CBT with younger populations or with older populations. It's just that when we use it with older adults, we need to be more aware of some of the potential adaptations to make it a more accessible and suited treatment to the person. So what that means is that it's a collaborative, goal-oriented approach. So you're not kind of treating the person from above. You're working with them to come up with what their goals might be. And as we'll see later, the goals that we're setting with people should be really realistic and meaningful to them. So it's not prescribing them things that they should be doing. It's working with them to explore, what would it look like if you were feeling better? What types of activities would you do? What type of activities have you stopped doing because you've been feeling depressed? So you're working with them to figure that out. And there's an emphasis on problem formulation. So instead of just relying on diagnoses, like a mental health diagnosis, for example, we're mapping out how a person's thoughts, emotions, and behaviors and the environmental factors around them all interact to maintain difficulties. And like I said before, that could include things like retirement, bereavement, health anxiety, sleep changes, loneliness, all kinds of possible contributors. So the formulation or this kind of understanding that we develop with a person really helps to guide a clear stepwise intervention because the person and the therapist should both be on the same page about kind of what the person's goals are. CBT also involves home practice or homework to reinforce learning. So the behavioral and the cognitive change really happens between sessions, and practice is reinforced every week. So for older people, that might mean that we're doing shorter exercises or smaller homework tasks. And it's important to really encourage success along the way. So that we can build momentum on making small change over the course of therapy. And the point here that says empirical, that's really that we frame exercises and homeworks as experiments. So we're trying to help people discover what works for them. And if something is tried, like a behavioral strategy is tried and doesn't work, we look at it with curiosity of, okay, how can we modify this to make it a better fit for you? So we monitor this with things like behavior tracking records over the course of treatment. So here's a quick snapshot of what a typical CBT protocol would look like. So this is the one if you have a therapist and you're doing like a standard CBT course. Usually it's somewhere between 8 and 16 sessions. It could be anywhere from 45 minutes to an hour, weekly to bi-weekly, depending on the person and the therapist's availabilities. And as I mentioned, it's very structured. So every session will start with kind of an agenda that you set with the person so they know what's going to be happening in that 45 minutes to an hour. And that includes time at the end to set homework for the following week. And the core components I've listed here: psychoeducation, cognitive restructuring, which that's the part of the treatment where we're really looking at unhelpful thoughts. We won't get into that as much today because I think the meat of what is really useful in day-to-day practice is more this behavioral activation piece. And at the end of treatment, it's a key part of CBT is focusing on relapse prevention and a long-term coping plan. So helping people ensure that they feel able to use these skills after the 15 or however many sessions are actually completed. So, as I mentioned, the cognitive restructuring technique is really the part about addressing unhelpful thoughts and then modifying them. I'd love to talk more about this, but for the sake of time, we won't get too much into that part today because it is a bit more complex. But with behavioral activation, this is the one where we're helping people get into activities that they don't necessarily feel motivated to do just yet. And as we saw back on that triangle, the idea is the more you get back into those activities, there will be positive influences on your thoughts or self-talk and also your emotions. Other techniques that, again, we won't talk too much about today would be exposure. So if you're doing CBT for anxiety, that might look like working on avoidance behaviors and gradually exposing yourself to things that provoke anxiety in order to increase function. There's also skills like relaxation training and mindfulness or deep breathing exercises that can be incorporated into the CBT sessions. And sleep hygiene is another piece that's often incorporated into CBT, but there's also a specific type of CBT for insomnia that I'll show you a reference for a little later, because that is something that is very accessible to clinicians and to people in the community as well on a website that came out of Dalhousie. So back to behavioral activation. So the reason this kind of works, which I mentioned a bit already, is that one of the best ways to change your cognition or your thinking patterns is through experiences. So when we set these small behavior change goals, the most important part of that is this increase in self-efficacy. So a sense that, okay, I achieved that, I can do this. So it's less about how big the goal is or what the goal is. It doesn't have to be something massive by any means. It's more about supporting people to achieve small goals so that they're thinking, okay, I can do this. Maybe I'm not as stuck as I thought. So it starts a pattern of behavior that tends to increase kind of quality of life and function over time. And a key thing to remember is that if somebody sets a behavior goal and it's not achieved, it's not seen as a failure. It's something that we warn people could happen, and we approach it with curiosity. Okay, so what didn't work? How could we reformulate this goal or make it a bit more achievable so that we can try it again? And so, as I mentioned, CBT has lots of evidence for younger people and older people, and the structure. So, some of those skills we've reviewed now, those don't change across the lifespan, but what does change is just the way that we present them. So, we're not kind of lowering the therapeutic bar. We're not minimizing the treatment. We're just using techniques to make it more accessible. So this could be something as simple as using a slower pace when you're working with somebody, doing more repetition, whether that's during the session or week to week, when you're perhaps reviewing what you did the week before at the start of the session. It can also be good to use really concrete examples when you're working with people so that it doesn't feel abstract. And that can be especially helpful if they have some degree of cognitive impairment that might make kind of abstract concepts harder to understand. Also, just using printouts with larger font size and less text, so more white space on a sheet can be really helpful. And for the people who do have more significant cognitive impairment, this would be another example. Say you were looking at doing a formal course of CBT. This might be somebody where you say, okay, well, let's focus more on that behavioral activation side of things. Maybe putting a lot of emphasis on changing thoughts isn't the best place to start. So just takes a bit more effort in kind of working with the person to determine where are we going to see the most benefit with this treatment given their circumstances and abilities. So now we'll look at some of the indications and the evidence for CBT in late life. So there are many situations when you could consider CBT, and I won't get into these in detail, but just to show you, when you're working with clients, when could you be considering, okay, maybe CBT would be applicable here? So depression and anxiety are the big ones. And there is solid evidence that CBT is effective for both of these conditions. Insomnia is the other one that has a lot of evidence behind it. And it's particularly relevant because in older folks, you're trying to help them stay off medications that might cause them more adverse effects than be helpful. And sleeping pills are a big part of that. So CBT for insomnia can be really helpful. And as I mentioned before, things like chronic pain, adjustment to major life stressors are all good indications. And even if they have mild cognitive impairment, as long as it's not to the point where they really couldn't participate in a session, then CBT could be applicable. If the cognitive impairment is more significant, we might come back to the start when we talked about something like supportive psychotherapy, where it's less of a structure, less requirement on kind of memory and cognitive functioning. So looking a bit more into depression, so the evidence is quite strong for CBT for depression. There are a number of meta-analyses and randomized control trials that show high response rates. So anywhere from, I put 50 to 70 here, but I think it's kind of 40 to 60 is a common citation in terms of the response rates. And typically, there's an even higher response rate for depression when CBT is combined with medication. But although the evidence is really strong across the lifespan, there is some mixed evidence about kind of how helpful it is for older adults. And this is part of the reason why we're doing a research study on group CBT to see, okay, let's build the evidence base to see actually how effective this is for older people. So it's really not just a therapy for young people, though there is lots out there that supports its use in older adults. And it's particularly useful, like I said, in combination with medication, but it's also something to consider if you are worried about the use of medication. So somebody is really comorbid or is not tolerating medications, psychotherapy is a great option. CBT is also a first-line treatment for anxiety disorders. So in the Canadian Coalition of Seniors Mental Health anxiety guidelines, CBT is in there as a first-line treatment. And The focus in the sessions would be slightly different from when working on depression. A lot of overlap, but it might be more targeted towards the excessive worry and kind of catastrophic thinking, and avoidance behaviors would be the big one that we see in anxiety that CBT can help address. So CBT is also a first-line treatment for chronic insomnia, and this is not just for older adults, but across the lifespan. And it's, many of us are familiar with sleep hygiene and talking to people about that. CBTI is more than sleep hygiene, so that's part of it. But there's also specific techniques like helping people restrict their sleep hours, do some cognitive work around kind of their beliefs around sleep, and it's shown to be very, very effective. And there's a link here, just tiny in the corner, mysleepwell.ca. This is a resource that was developed at Dalhousie University by Dr. David Gardner and colleagues. And really the evidence suggests that it can be more efficacious than medications. So very, very effective when we're trying to avoid sleeping pills in that population. So something else to think about, because you can direct people to this website to explore the resources on their own, but they also have specific resources that clinicians of all backgrounds can use. So lots of evidence for CBT for multiple conditions. It seems like it's almost applicable. It's a really adaptable therapy. And just to remember, it often has longer lasting effects than medication, or you can use them in combination. And you can make lots of adaptations to meet a person's needs without reducing the effectiveness of the treatment. So now I just want to highlight some practical strategies. So looking back at the behavioral activation side of things that non-psychotherapy clinicians can apply in routine care. So before, when we talked about the intensive interventions like structured psychotherapy, they're great, but yes, they're often more difficult to access. And so when we look at kind of other options that clinicians have in day-to-day practice when you're trying to support people around health behavior change, whether the goal is, for their physical health, or if it's for a condition like depression or anxiety, or to promote cognitive health over time, you've got the kind of lower intensity things like giving them handouts, brochures, information that they can take at home. But we see that the uptake generally is lower in terms of actually making the change after people get that type of information. And then some clinicians also use the strategy of prescriptions. So prescriptions for exercise, prescriptions for socialization. And some studies would suggest that that is a bit of a higher response rate because there's more of that connection with the clinician and seeing it as something that really can be followed up on. But the evidence really gets kind of more robust as we get into approaches where there's actually some support provided around setting a behavior change goal and then tracking it over time, which is what we do with behavior activation. So here I'll introduce the Fountain of Health initiative for optimal aging, or wellness over the lifespan. So this was founded by Dr. Cassidy, who's a geriatric psychiatrist, and really has focused the Fountain of Health as a way to apply some of these CBT-based tools for health promotion, well-being, or targeting specific conditions like depression and anxiety in older adults in really practical formats. And one of the central parts of the Fountain of Health, or one of the central models, is sometimes called the 5-minute CBT model. So how can you apply this in your practice in just a few minutes? Because everybody's really busy and we need strategies that we can just slide into routine appointments. So I'll put some more resources up as we go through, but just to start off, you can see there's a website here and also a link for an app that we'll talk about where you can direct people to help track behavior change goals over time, but we'll come back to that. So the Fountain of Health has a model called Thrive, which relates to this idea of setting small goals in practice. So it's a three-step approach centered around these Thrive areas. So they stand for our thoughts, health habits, so things like exercise, nutrition, our relationships, interests or hobbies, or challenging your brain and learning new things, and also emotional well-being. And the V stands for kind of values. So looking at setting goals within one of these areas that are actually meaningful to the person, not just prescribed kind of from above. And so these areas of Thrive were selected because they have the most evidence for addressing mental health conditions, promoting cognitive, physical, and emotional well-being. So there's a lot of evidence behind these areas, and that's why we encourage people to think about setting a goal in one of these. So the first step is inviting your patient or client to assess how they think they're doing in these areas. And is there one that they would like to make a change toward? So exercise is a really common one, but also relationships where people have a lot of social isolation. They might be looking at increasing their social opportunities. So once you ask people to look at how they're doing in these areas, the next is to actually support them in setting a goal. And we'll look at how we can do that in a brief intervention, but to make it more likely that they'll actually achieve it. And the third really important step here is to support them in tracking it over time. So either kind of directing them to something like the app where they can track it themselves, or using a printout that you could keep in your office and follow up with them at their next routine visit, for example. So to summarize that, again, it's kind of 3 steps to help someone get started with behavioral activation. So assess how they're doing in these evidence-based areas that we know promote health and cognitive function, well-being. Then we support them to set a SMART goal, and I'll explain what that is for people who aren't familiar with that acronym. And then we help them track it over time and repeat. So the idea is once you get started with this, it's the first step towards a larger change. So really small goals, but achieving them and perhaps building on them over time. So in practice, if you have a patient and you think, okay, maybe they're, depressed, or they're isolated, or, many different issues, and you think a behavior change could potentially be helpful, the first step can be having a conversation with them about how ready they feel to make a change right now. Because that's really important. If somebody's not feeling ready, you don't want to push this type of intervention on them. So asking them, for example, what matters to you most right now? Like, are you bothered by the way things are going? Are you interested in changing it? Are you ready now? So you can get a sense of whether this is a good time to actually do an exercise like this. The next step is to get them to do this little self-reflection about how they're doing in each of those key areas. And so these are some sample questions here, but I'll show you there is a handout you can use on the Thrive website where you can kind of print it off for people and get them to fill this out manually, or they could answer these questions on the app to help them figure out where they might like to make a change if they don't already have a good sense of that. The next step is, once somebody's identified an area where they'd like to make a change, is to support them to make it achievable. And so SMART really breaks this down in terms of setting a really specific goal, because most people would tend to set like really lofty goals that aren't specific. So I want to be in better shape, or I want to have more friends. I don't want to feel as lonely. Those are great ideas, but it's really hard to implement those or to track them over time because they're so broad. So it's really getting a person to break down each of these steps so that the goal is trackable over time, and we can see if it's actually making a difference. And we often use something called the 50% rule, which is once they have set a goal and you think it's achievable, encourage them to cut it in half. Because again, it's not about what the goal is, it's about reinforcing that you can achieve it. And then that is what helps lead to that sense of efficacy. I can do this, I can make other changes in my life too. So, for example, if someone had a goal like, I want to walk my dog for 10 minutes a day, you could say, well, we could make that more specific. So I'll walk my dog for 10 minutes in the morning, 3 times a week for the next 4 weeks. So it's really clear, gives you something to easily check in on at the 4 week mark, for example. And these are just some examples of what these micro or really small SMART goals might look like. So call a family member to chat once a week for 4 weeks. Write in a gratitude journal 3 nights a week before bed for 4 weeks. Not all of these examples are kind of tailored to older folks, but it's just to give you an example of how kind of specific and small they can be. And then once you have the goal set, like I say, they can use this app, which is it's just a web-based app. You don't have to download anything, where they could keep track over time of how they're doing with the goal, and they could also set things like little reminders to keep them motivated. And then there's a checkout at 4 week where they can see kind of how they did with the goal. And for people who aren't kind of interested in the tech side of things, there's also a sheet you can download from the website where you can write down the goal with the person in a clinical setting or in community-based settings, and then use that to check in at a time point down the road, whether that's 4 weeks or if you set a different time point with your client. So again, bringing it back to kind of 3 steps. How do you start behavior change or behavior activation with people? First thing is kind of get a baseline, see how they think they're doing in these areas known to promote health, see how ready they are to make a change. If they are, help them set a small goal and then track it over time and repeat. So it's something that can kind of be an ongoing process. And this is just a link again for the Thrive website. So there's you can direct people directly to this website. So even if you don't have time to maybe go through all of this with your client, the information is all on the website, so they could read about it themselves. But there are also links for clinicians where you can download some of the content that I've talked about. There's also more information in the community about how to apply these approaches. This is just one example of some webinars that are happening. Some of these have passed now, but there are some webinars that Dr. Cassidy facilitates. Most of these, I believe, and there are a couple left in the new year that relates to some of this kind of content about supporting people with behavior change. So just a few minutes left here because I will keep it to 45 minutes. So I'll just kind of quickly mention a study that's underway that might be of interest to people about a group CBT, because we've talked mostly today about kind of what therapies you can use one-on-one with folks, and then how to apply those skills even when they're not doing formal psychotherapy. But there's also an option of group psychotherapy, so to increase the accessibility for a larger volume of people at a time. And so we're currently in the early phases of doing a controlled trial to assess group CBT that has been modified for older adults. So with the adaptations that we've talked about today, like using big font size, a lot of repetition, checking in with folks between sessions to enhance the uptake. And we're comparing that to kind of treatment as usual. So I'll just skip through some of this for the sake of time. But to give you a little overview of what group CBT would look like compared to the individual protocol that we looked at the start of the session, typically there'd be two co-facilitators. It's in person, at least for this study. It can also be on Zoom, which was happening more in COVID. But it's an 8-week program with 2-hour weekly sessions, and the sessions are all laid out by kind of a manualized protocol. And this is something that Dr. Cassidy has kind of spearheaded, and it's a manual that is really outlines the content week to week, and the therapist can use that to guide the sessions. And this is something that, because it's part of the study right now, it's not something that is kind of publicly available at this time, but that could potentially change over time. But for now, this is what's being used for the study. And like I mentioned, lots of modifications used for this type of therapy to increase the uptake. And these are just, this is just a layout of kind of the sessions that we would do week to week. So you can see there's one that just introduces CBT, talks about SMART goals, etc. And then every week has a slightly different focus. But what's consistent is that there's always repetition about the core content, like the CBT model, SMART goal setting. We do those every week to reinforce the concepts over time. So we're hoping that it'll show that the group is effective compared to regular treatment, and if so, that this could be potentially increased as an available resource to just have more options for people to engage in psychotherapy. So I'll skip past these little nitty-gritty details because we're at time, but happy to answer any questions about the study or any of the other content we've talked about. So 9:16, Caitlin, not 1 minute over.
Fabulous. Yeah, thank you so much, Dr. Gough. That was really applicable.
Thanks.
So yeah, let's open it up. We got the chat open. If anyone has any questions, feel free to go for it. Quiet today.
Just that good.
Okay.
It was very, very informative, and I think applicable to day to day. We have the PowerPoint after the presentation. So they are being recorded, and the link for the YouTube sessions are there as well. Yeah. Yeah, Karen, go for it.
Hi, thank you very much for your presentation. As a speech pathologist who, spends a lot of time with seniors, I so often find myself in a situation where seniors are talking to me about their problems, which professionally speaking is very appropriate. But of course, I'm not a trained mental health professional, and I never want to present myself as such, and I never want to be seen as giving, psychiatric advice or psychotherapy or anything like that. But to your point about seniors and mental health stigma and just seeing, mental health as, talking about mental health as a sign of weakness. Do you have any more specific strategies on what I might be able to do to get people thinking more about mental health professionals instead of just using me to unload on things that I'm not necessarily trained to deal with?
Yeah, that's a great question. So, I mean, some of it is a generational thing, because I think even in terms of what therapy looks like now compared to when a lot of older people today would have been kind of in their youth or younger adults, the landscape is very different. So what I find is that a lot of people have this idea that mental health equals institutionalization or equals lying on a couch talking about like your childhood and your mother and your father, which there's, that's a whole different topic. But I think there's just a lot of ingrained ideas because things were a lot different a few decades ago. So something that I find helpful in talking to people about it is to just use really plain language. So not necessarily to be framing things like, have you considered psychotherapy or have you ever thought about talking to a psychiatrist? Is more to work with them on like if they're telling you that they have a problem or a concern, keeping it kind of general to say, like, have you ever thought you might like to talk to somebody a little bit more about that? Or, you mentioned you don't have much in the way of supports right now, like not much family or friends around. Do you think like you'd be open to chatting with somebody who has some experience in this area? Or even framing it more so around the like behavior side of things. So if they're saying, I'm not doing anything, I'm sitting at home all day, to say, there are some programs out there that support older people to get more active in the community. Do you want to hear about any of those examples? Because I think for some people, it is going to be like, yes, they need a referral to mental health if there's a real concern around like a depressive disorder and anxiety disorder. But one thing I didn't mention in this talk today, which I probably should have added in, was there are other kind of lighter interventions that are still really effective in the community and might not have much stigma, like the community health teams. So there's a community health team session on called Optimal Aging, but it has a lot of this content about like behavior change and supporting your mental health. But a lot of people find that more palatable than perhaps going to see a psychiatrist. So I think kind of framing it in plain language and linking it to what they're telling you are their concerns. So using their language as to what's a problem right now can help open the door a little bit. And then also, if you've got, like, if they have a trusted partner, whether family member, somebody who's with them, sometimes involving them in trying to encourage the idea over time can be helpful. Because at the end of the day, some people are just more resistant and might only kind of take the advice of somebody that they're close to as to finally kind of reaching out to get help. So hopefully that kind of answers your question, but it's a tricky issue for sure.
That's very helpful. Thanks very much.
Okay, so it sounds like there's more comments. It sounds like this would work very well with rec therapy, as there are several overlaps, 100%. I think any of those real, like, meaningful point of contacts, we could apply this.
Yeah.
So from a nurse in long-term care, Zelda, she said, do you think that CBT could help someone with Parkinson's and REM sleep disorder?
Yeah, so I think it certainly could. Kind of depends, I guess, what the person's goals are. But for example, like in Parkinson's, that would be a great example of depression is really, really common. Anxiety is really, really common in Parkinson's, and also a lot of functional changes that come with the condition. So the strategies around behavioral activation can be particularly helpful when you are supporting somebody to set a goal that might be more reasonable now with their functional abilities compared to what they used to do. So for example, I had a lady not long ago doing CBT for Parkinson's, and it was a lot about reframing, like for physical exercise. That was a big goal for her, but she kind of continued to set big goals that were getting really hard with her Parkinsonism and with balance issues. And so it was supporting her to use some of these skills to reframe the goal around like gentler exercises focused on balance. And she ended up joining like a dance for Parkinson's group where they did a lot of balance. So in that sense, it wasn't necessarily like a formal CBT, but it was more using that behavioral change technique to support her in feeling like she had more activity and doing things that were more accessible and meaningful to her over time. So definitely applicable. I think the question that sometimes you might not be able to answer, and that's where you can bring in like the family doctor even, is you might not know, okay, do they need like an actual referral to the mental health team? But I think regardless of what's going on, most of these kind of more practical skills around behavioral activation are applicable to everybody, even if you're not like completely depressed or anxious.
Excellent.
Hopefully that makes sense.
Yeah. Another question, how accessible is CBT to lower income people without coverage?
Mm-hmm. So that is a big challenge, and that's kind of at the start where I was saying, sure, if everybody had access to formal CBT, that would be great, but access is, I would say, quite limited. So for most people that we see in a tertiary clinic here, we have a psychologist on our team, for example, but we have a lot of clients and one psychologist. So people would then be left to go look at private psychology. And I would say most insurance plans would cover like the initial couple of sessions, but not a full course of CBT. So it does really become a barrier because you're paying out of pocket. It could be $200. That's just a ballpark, like for a session, perhaps. So for many people, that's not accessible. So that's why we try to incorporate the skills, like the behavioral activation, in more routine care, and also why, one of the drivers of why we're looking into the effectiveness of group programs, because over time that could be another way to increase accessibility for a larger volume of people. So to get like 10 people in a CBT group at a time would certainly increase access compared to with a one-to-one therapist.
Mm-hmm. Okay. So lots of thank yous. And then with the health behavior change slide, does it seem the more individualized the intervention, the higher the response rate? Is it the relation/social aspect of the intervention? What furthers the response?
Yeah, that's a great question. So I would say that what what is a great predictor of response is focusing on that first step of getting the person to assess where they would like to make a change. Because when we saw that slide about the Thrive model that kind of summarizes all those areas, like you said, whether it's socializing or physical activity, the big piece of the Thrive is the V, which is it has to be something the person values, because that's really going to increase the likelihood that they'll do it. So there's no use, or there's little use, if you've got someone in front of you who is actually feeling pretty good about their physical activity levels, or maybe they have, a functional ability that doesn't allow them to increase their physical activity. It's not going to make sense for that person to say, the guidelines suggest you should be exercising three times a week. Let's set a goal around that. For somebody like that, they might say, I actually want to have more social opportunity. And so I think listening to that at the start, like before you set a goal, is one of the best ways to ensure that the goal will be meaningful to them. And then they're just so much more likely to actually want to practice it, so that it doesn't feel like a should, it's a want.
Excellent. Okay, Dr. Gough, I think that is all of our questions so far we have today, unless anyone has anything different or more. Looks like that might be it. So thank you all for your time today, and a big thank you to Dr. Gough for presenting. This was really great. I believe our next session coming up, if I can open it, is happening on January 8th. And that's with Dr. Lauren Haslam, and it's a pharmacology session. So if you all want